Today, we're going to be exploring the critical topic of data for improving health outcomes. And we're delighted to be kicking off and building on the learning from before and having an exciting lineup as well to take us through a number of topics and a number of angles through which we can explore data and what it means to us and what it means for the people we serve in Sussex. Data is all around us. It informs everything from the weather apps we check each morning, or WhatsApp, or to the healthcare decisions that save lives. Yet we know that understanding and trusting data can vary greatly, and its effective use is often a challenge. This is why a webinar like this is crucial. There's a well-known saying, I think it was William Edward Deming, who said, "In God we trust, all others must bring data," which highlights just how crucial evidence is for informed decisions. And last webinar, we talked about quality improvement, which is all about that. The design of interventions, not based on whim or hunches, but based on solid data, quantitative or qualitative. More recently, you'll remember there was a Data Saves Lives campaign, and that's a nod to that in this slide. And it showed how harnessing the right data at the right time can lead to faster diagnosis, better care, and ultimately save lives. But it's not just about using data, it's about using it wisely and responsibly, as many other things. And recognizing that data allows us to pinpoint inequalities, target resources more effectively, and essentially ensure that the right care reaches the right people in the right way. So it's a vital tool in creating a fairer, more equitable, more sustainable health and care system, and even society. And that's what today's session is all about. And I'm thrilled to have such a range of speakers who will inspire us with practical ways to use data to close health gaps and improve outcomes for everyone. And before we dive in, just apologies for anybody who was inundated by an email inviting people to a webinar, a separate webinar, not linked to this one. And we will review our sign-up process to ensure that doesn't happen, which is quite timely given that we're talking about data and trust. So just want to express our apologies for anybody who was inundated by that communication, and we will review our process to improve that. Now, in terms of our lineup, I've said what I've said, and I'm shortly going to pass the mic on to Kerry Dudley from NHS Sussex, who is going to tell us a bit more of why this is important.
Thanks, George, and good morning, everyone. As George said, my name is Kerry Dudley, and I'm Head of Population Health and Inequalities at NHS Sussex. It's really exciting to have so many of you with us today because it really reflects our shared commitment across Sussex to improve the health and well-being of our communities. Before I talk any more about the upcoming webinar, I'd like to introduce Nikki Cambridge, who joined us at the beginning of January as our Deputy Director of Population Health and Inequalities. Do you want to just say hi, Nikki?
Yeah, I will definitely say hi. Thank you, Kerry, for introducing me, and agreed. So amazing to see so many people on the webinar. And having recently joined the team, this is my first webinar and I'm really looking forward to it. And I hope to connect with some of you both during and after the webinar as we go forward. Thank you. Thanks, Kerry.
Thanks, Nikki. Great to have you with us. As George alluded to earlier, data is really at the heart of population health management, as it really helps us understand where disparities exist so we can best direct our pressured resources to effectively deliver more equitable outcomes. Our co-produced Sussex Improving Lives Together strategy underscores this, particularly in Delivery Area 3, which focuses on addressing health inequalities and creating healthier lives for the people that live in Sussex. But we really can't achieve this ambition without robust data to guide us. Data follows us to measure what matters, while digital tools enable us to act on these insights, making care more accessible and supporting individuals to take charge of their health. As George said earlier, whether it's connecting data sets to reveal hidden disparities or using apps to access, help people take charge of their care and to engage with people from underserved and underrepresented groups, Digital innovation is central to transforming health and care. It will help us deliver the 3 left shifts described by Lord Darcy last year, from hospital to community, from sickness to prevention, and from analogue to digital. In Sussex, we're ambitious about using data and technology to create meaningful change. And today we'll be sharing some of our plans and initiatives. I'm really looking forward to hearing from our speakers as they share their insights and experiences in driving this important agenda forward. And I'll hand back to George to carry on.
Thank you very much, Kerry, for helping us set the scene. And now we are going to kick off our interactive poll. So you'll remember from our previous webinars, before we start the webinar, we want to get a sense of your knowledge and confidence in the topic, and today's topic obviously being about using data for better health outcomes. So we're going to have a few questions, one question this time, just for you to respond to, and we're going to ask the same question later on in the webinar. So if you can let us know before the start of this webinar, how would you rate your knowledge and confidence in using data for better health outcomes? Also from Health Innovation, Kent Surrey, Sussex, leads our work on population health. But Lucy, I don't want to steal your thunder. I'll hand over to you to introduce yourself and the 2 principles of data and digital that you want to talk us through.
Thank you, George, and good morning, everyone. So yeah, I'm Lucy Hooper. I'm a Research and Innovation Manager from Health Innovation KSS and lead on our population health portfolio in health inequalities and health equity. If we can actually head back over to Slido, because I wanted to start off just with a brief quiz. So if you've joined previous webinars, you will have seen the 10 core principles for health equity. So these were developed by our Chief Medical Officer, Dr. Marianne Ferret, and each webinar we dive into a couple of these principles. So the 2 principles we'll explore today are data and digital, which I'll tell you a little bit more about just to set the context for today's session. And just to make you aware as well that we've developed these principles into some resources in guides tailored to different audiences, which I'll refer to at the end of my short presentation. And just to say, just do get in touch with me if you'd like to discuss them or find out more about them. So next slide, please. So the data principle, that's about utilising data to understand more about the issue at hand, such as to understand more about population demographics, or to explore certain health conditions to understand who's more likely to have a certain condition, perhaps at what point they're being diagnosed, what outcome variation may exist, or who is or isn't accessing appropriate services, as well as what patient experiences of services are like for them for different population groups. So you'll want to consider where there are gaps in the data and if alternative data sets you could use to deepen your understanding. You might also want to explore intersectional factors such as comorbidities or exploring the relationship between mental and physical health. And that can be done through linking data sets and population health management approaches. Data is also used to measure impacts and success factors. So you'll want to establish early on what improvements you would need to measure and the data you would need to refer to or collect to measure impact. So this may be on a range of metrics such as waiting times, improvements in outcomes, patient experiences, and wider social and economic impacts. You'll also want to build in the ability to disaggregate data so you can measure and demonstrate health benefits for different demographics, such as for men and women and ethnic or socioeconomic groups. So data really does drive understanding and evaluation and to demonstrate improvements in not just overall approaches, but to kind of understand improvements for different demographic groups as well. So next slide, please. So the digital principle is about identifying and investing in digital solutions that improve access to services and improve health. It encourages us to embed health equity within both product development and implementation and evaluation. So it encourages us to consider what adverse impacts or unintended consequences could result from a digital solution, which vulnerable or minority groups could be negatively impacted by digital technology, how could adverse impacts or digital exclusion be prevented or minimised. So it's really important to build in health equity considerations from the development stage of a digital solution to ensure it meets the needs of all users, and through to implementation to ensure it be accessible for all. Next slide, please. So it's also important to consider data biases and to be aware of why and in what ways they manifest in digital AI and innovations. So biases are founded on systemic and historical factors where throughout history, marginalised groups were and to some degree still are often accounted for in science and healthcare. Research in science has in general been led by white privileged males who also make decisions around what research should be funded, which has resulted in certain clinical areas being neglected, such as women's health, research and innovation. Clinical trials have also, in general, been conducted on white, young, healthy males. So the data that is collected that informs science, innovations and treatments tend to be tailored towards men and may not be applicable or suitable for all, which can result in poorer outcomes for those neglected population groups who are unaccounted for. So just wanted to set some context there, but I'm really looking forward to hearing from the speakers today, and we'll be passing the baton on shortly. Before I do that, I just wanted to leave you with some resources that can help you in considering health equity within digital and data. So the first one is the Digital Inclusion Framework, and that was developed by the University of Sussex, NHS Sussex and Health Innovation KSS. And it also informs the National Digital Inclusion Framework. So please do refer to this if you're developing or implementing any digital solutions. Next slide. So finally, here are the resources and guides that can support you in embedding health equity in your work. So we've got the Innovator Guide and Commissioner Guide to Health Equity. So I'll be talking to the Commissioner Guide at the next webinar in more detail. But please do refer to these and do get in touch with me if you have any questions or would like to discuss these at all. So I will now pass over to the next presenter.
Thank you, Lucy. I am not the next presenter, but I will be passing the mic on to our next presenters, even Jacqueline Clay and Kerry Dudley, who will be talking us through yet another framework. So from one framework to another, the health equity framework, which we'll share a link to, and you saw in the slide earlier. This is one that is very much a local one in Sussex, and I don't want to steal Jacqueline or Kerry's thunder, and they'll talk us through what it is and how and why it matters really to the work that we're doing across Sussex to tackle health inequalities and improve the health of our population. So Jacqueline and Kerry, over to you.
Okay, so my name is Jacqueline Clay. I manage the West Sussex Public Health and Social Research Unit in West Sussex County Council. And I'm going to talk you through what's called the Sussex Population Outcomes Framework. Or we call it POF. I won't keep saying the whole thing. So, and Kerry Dudley, you will help, I think, at the end here when we look about how this is being progressed within the NHS and some of the issues on data quality. So this outcomes framework started back over 2 years now, October 22, and it was initiated by the then Sussex Population Outcomes Committee, who wanted a framework which really brought together the whole range of outcomes and measures which contributed to population health. And in public health, in local authorities, we were asked what would be the key measures we would look to if you were looking at population health. So the key aspects were looking at the largest contributors to ill health, and particularly impacting on healthy life expectancy and life expectancy, to also align that to existing measurements, particularly in existing frameworks, but also in the work of things like the Core 20+5, which is the NHS's approach to health inequalities, and also to look at measures irrespective of whether they were process, access, clinical, social, or wider determinants. So it's a huge range of measures included. There was a considerable engagement of this. It's quite dry engagement to get people to talk about outcomes. So there was a lot of engagement with both clinicians, with different existing governance groups, to look at the kind of measures that might form an overarching set of indicators. And they've also been included in various other sort of reporting measurements like the ICT data packs. I realise some of these are local, but as we go on, I think some of these will have wider sort of implications across the system. So when you're developing an outcomes framework, obviously you've got to think, well, what's it for? Who is it for? How is it going to be used? What decisions are going to be based upon it? And also, what's the ultimate drive of the outcomes framework you're adopting? And here, just to go to the last point here, the overarching outcome for this framework is that people will have longer, healthier, happier lives. That's the ultimate outcome. And there are those three key measures there on life expectancy, healthy life expectancy, so the period you could expect to live without a major disability or chronic disease, and crucially for health inequalities, the gap in life expectancy, whether that is geographically, which we see quite a lot, or whether or not between different groups within a population. But there are some challenges with developing a framework. One, this is about a whole system. This isn't an NHS framework or a council framework. It's about a whole system, so it's not confined to one organisation or sector. We wanted to include factors that also relate to promotion of good health and prevention. So it's not just measurements of progress against a pathway or measures of ill health or care or treatment. Obviously, we need to reflect the major burdens and risks for poor health. So our go-to in that for public health will tend to be things like the Global Burden of Disease study. But we also wanted to, and I think it's a big challenge, include outcomes that relate to individuals and their experience of service and the quality of life. Crucially in this, we need to align to existing frameworks. Nothing in this outcomes framework was to create new collection of data or duplicate something that was already going on. It's a high level oversight, so we can't include every measure. And as I say, it needs to also look about subgroups and geographic differences. I think it's just fair to say it's been a very dynamic process. I think it changes. So as new measures come out centrally from the NHS, but also we are seeking, I think it's true to say, better measurements of experience, true outcomes. There is some tension in the framework on things that are very long term, things that are short term. How do you include things that are complex measurements, such as child poverty? Who owns issues like that? But we all know the system itself has impacts on those wider determinants that have very longer term influence on disease and health overall. There's been a long discussion on whether or not you should have separate measurements. Should you have a separate outcomes for clinical outcomes? And then we know there are some really key gaps. And one example of that is there was a lot of call for, surely there's some measurement on the experience of people, children with special and educational needs, or transition from children's to adulthoods in services. So we know there are gaps in this that people would like to see addressed. I won't repeat everything on here because I think I've covered some already, but certainly time lag is an issue. There is often a wish for real-time measurement of things if you're looking at performance, but many of these measures at population level take many years to influence. There are existing governance reporting lines, so it's really important that we didn't duplicate. So the maternity system, for example, do lots of measurements, many more measurements on maternity, cancer services. So each different reporting lines can be quite different. And I think it's that true outcome. What is a true outcome? And I think there's some really good local measures being developed for example, on MSK services, but we felt it was very important to be able to benchmark nationally on most of the measures that are included. So now, don't take fright. This is what it looks like, and it was very important to us. We get all of the measures on a single page. And don't worry, there won't be a Slido asking you to name what 4.3 is or whatever. We started naming these because we needed to start keeping track, and we've got a metadata now at the back of this, looking at the measures included. So you can see here that we have the major burdens of ill health. We have many of the maternity measures, child measures, measures around mental health. Also, if I just move over here, there is also inclusive elective is included in this. But I'll go on to the next slide just to look at the format of how this has been structured, if it will move on. So what we have is each domain, so there are 12 domains, has a high level, if you like, a sort of a priority indicator. And then below that, a series of indicators or measures that are meant to be promoting that key measure. It's not perfect. So you could ask, well, what does oral health do here to help improve the readiness for school? And then the measures are also organised sort broadly from prevention to secondary and tertiary prevention and treatment. So if you're looking at cancer, for example, well, we're looking at, well, smoking prevalence would be a starting point on prevention, and then you're going through to treatment and the tertiary level, so secondary, so screening and then treatment. And you can see here we've also put which measures are core 20, so NHS core 20, and HI state are the health inequalities statement ones that came out from the NHS. And we also would hope that most of these would have sub-measures. So if we're looking at readiness for school, for example, well, how are children, all children, but also children who are eligible for free school meals doing on that measure? So it does look rather complicated. How we would see this, who we would see using this, is really senior board members, if you like, within an ICS. You might want to see across a system who don't go to the maternity service board or have detailed measurements of cancer treatment or respiratory. So it's meant to be a whole system measurement with the overarching outcomes really sort of included at the top. So that is what it looks like. And as I say, those three overarching measures are always kept in mind. And particularly healthy life expectancy, I think now, which has implications not just for individuals or communities, but certainly has an economic issue, as that is falling now below state pension age. So healthy life expectancy, you can see an increasing driver in the government's push for growth. And then the gap in life expectancy also between different groups of the population, different areas. So we're always keeping that as sort of, I hate to say it, the golden thread right throughout the outcomes framework. And we do have challenges, and there are different challenges across the system. So we have pretty good life expectancy. Just to speak here for West Sussex, we have pretty good life expectancy, but our healthy life expectancy has really stalled or really fallen for women. And we have some big gaps in life expectancy between some more deprived and less deprived areas. And it also aligns within the NHS to some of those key reports that and drivers of delivery plans, the Darcy report last year and the NHS long-term plan. So there needs to be alignment, and that is why you will see adjustments to this if new measures come in, alignment to those key drivers within different parts of the system. And also the social care, I know, has had different measures within the social care outcomes framework. In terms of communicating this, when you've got so many indicators, it's quite difficult to communicate to a system how an area is doing. And this is just an example of the public health measures and some of the clinical measures, some of the other measures within that framework, communicating this for West Sussex. And this is an infographic approach. I think the NHS will take a much more dashboard approach to, and we can include that for the system on some of the key measures. But here we're just looking at, we've now drawn infographics which include the key measures in that in the population outcome, in the POF for West Sussex. But I think these are some very longer term measures, and often measures that are only updated annually. And perhaps also this is too centred on a RAG rating approach to looking at measurements. For example, although smoking, we're often seen as green in West Sussex, we know that is a massive driver for ill health in the longer term. In terms of the ICS, we know that there are some POF dashboards under development within the NHS, and unfortunately some of the leaders in that system couldn't be here today on some of the developments within the dashboards. There is clinical ownership through the clinical leadership group and system ownership within integrated care teams as well. So there's lots of levels by which these measures are being viewed at. It's not just the overarching Sussex level, but you then take down to place or within sort of clinical areas or groupings within the system. So it gets quite complex once you go beyond that one sheet of measures. And I think, Kerry, you're now going to look at the issue here, which is, as all outcomes frameworks depend on, which is good quality data. So I'm just going to hand over.
Thanks, Jacqueline. As Jacqueline has demonstrated, the development of the POF has been multidisciplinary and a genuinely shared endeavour, and it will continue through the next stages of implementation and oversight. But to be effective, evidence-based decision-making for the POF needs to be fed by really good data, good quality data. Can I have the next slide, please, Jacqueline? Yeah. We recognise this in Sussex and we're working really hard to address this. In year one of the shared delivery plan that Jacqueline mentioned associated towards our strategy, we achieved our target of 90% ethnicity recording data completeness. However, when we delved underneath that a little bit more, we found really high levels of not stated and not known, which I'll talk about a little bit more in the next slide. So in year two, we made improving data quality one of our shared delivery plan priorities. This has included co-producing data packs for each of the integrated community teams. 13 of those are emerging across Sussex at the moment. And you might have heard them called nationally neighbourhood teams. They're the same things. We co-produced data packs for each of those. We've improved ethnicity data in the Sussex integrated data sets as well, which you may have heard called SID. So that's our integrated data system. Working with our population colleagues through the Sussex Digital Data Panel as well, we've really been able to hear about some of the challenges around people feeling comfortable about digital and data. And we've been working with our partners, including providers, to co-produce the Sussex Population Outcomes Framework, which again, I'll talk a little bit more in later slides. Could I have the next slide, please, Jacqueline? Thank you. So as I said, whilst we've got very good data completeness and we're showing over 90% across Sussex, we also need to understand the high usage and high variation of the accepted coding of not stated and not known. So not stated is where an individual has been asked but chosen not to identify their protected characteristics. And not known is where colleagues have not been felt able to ask or been able to report on someone's protected characteristics. Not having this data, although our data completeness looks really good on paper, it's really limiting our ability to understand how people from underserved and underrepresented groups are accessing care and explore what barriers they may be facing, although we are starting to have those conversations with our digital panel. Next slide, please. It's Jacqueline. In response to that, we've co-produced the Sussex Health Inequalities Digital Improvement Strategic Framework. I stuttered over that because it's not the easiest title to speak to, but it will be working alongside the Population Outcome Framework. So you can see through the framework that we've made commitments in areas such as building trust. And that's really both with our population, whilst supporting staff confidence to have those conversations around data and getting that data information. We're really committing to improve our data quality so that we can make that decision making that George talked about at the beginning, by ensuring we've really got good quality data and the analysis drives that decision making. We want to work through education and forums like our Population Health Academy to help staff feel confident and help patients feel they can self-report. So the framework has been developed through this year. We started to socialise it at the end of last year, and it's been shared with NHS England and nationally, and providers have just completed their final review. So implementation will be moving alongside with the population outcome framework, so that we're really looking at data from all areas. And I think that's the end of our presentation. So we're happy to hand back to George for questions.
Thank you very much, Kerry and Jacqueline. What a comprehensive, albeit in the short space of time, comprehensive walkthrough a tool, a framework that, well, first of all, we should all be aware of now and can see the benefits it can help us yield, or at least where it can signpost us to, regardless of what setting we're working in or sector or what specialty or population groups we're working with. I'm trying to see if there are any questions in the chat directed to yourselves. We're getting thanks, so the thanks has been echoed, Jacqueline and Kerry. I guess the question I have is, if people wanted to access this, I know the slides will be shared. If there was a call to action you wanted to issue to people right now with regards to the framework, what would it be, Jacqueline and Kerry?
I think it is to be aware of it, and also I think it is an iterative process, because I know, especially with the new government, that there will be different measures that come in, there will be different drivers, and it is to ensure that this is kept relevant. And I think it is not meant to capture everything. It is meant to capture the key measures that people would want to communicate about an area to the wider system. And I think that is a challenge, but it is to ensure that dialogue, I think any outcomes framework should be a dialogue, and it should make sense to the people right at the front line, but also right to senior management. So it is keeping that dialogue open. And there are some measures which I think were desired, but we still need to develop. So what would be a good end of life care measure? What would be a good measure around transition? And I think the system needs to sort of think about how those things can be best measured.
Thank you, Jacqueline. Well, that dialogue certainly has started, and we've got some comments in the chat, particularly around children in care and care leavers. So just noting that comment there, and thank you, Sarah, for sharing that, and Dawn as well. It's 10:47, and we are now going to move on to our next item and our next speaker. And I'm excited to bring to you, or introduce to you even, Ruby Jackson, who is a newly qualified midwife and the founder of an app, a digital solution called Melanatal, a groundbreaking digital tool which is designed to address the stark health inequities faced by babies with black and brown skin and their families. So today, Ruby's going to share how this inclusive innovation and potentially other inclusive innovation can bridge health gaps in maternity care and equip clinicians as well as families with the tools to improve outcomes and experiences for some of the most underserved communities. But Ruby, I do not want to steal your thunder. I'm going to pass the mic over to you now to talk us through Melanatal. Welcome, Ruby.
Hiya, welcome everyone. Sorry, I'm talking on my phone because I'm actually on a clinical shift, so just had to nip off. But yeah, thank you so much for inviting me to present today. And yeah, I'm just going to be going through a bit about the app itself, but also the background of it, the kind of rationale behind the reason why I developed it, bit about my personal story, and then we'll be touching on things like digital inclusion, co-production, and then what's kind of next. Next slide, please. So outlining the problem, so looking at the background context, the journey to creating the app, the features, the future kind of impact, what's next, and then at the end I've just added my contact details. So next slide, please. So the problem, this was something that I actually focused my dissertation around. So I did a practice change proposal, and within that I did a literature review, and some of the common themes around why Black and brown mothers seem to be having adverse outcomes and also experiences was that within our education, and this is both in university level and in clinical practice as well, there is a massive Eurocentric lens on medical education. So often we're shown images of white families, white mothers and white babies, and there's a massive lack of representation and inclusion of Black people within medical literature. And within the literature review I did, a study actually showed that less than 5% of medical textbooks included images of conditions on dark skin tones. And this was a general study of, it was over 1,000, I can't remember the exact number, but of medical textbooks, and only less than 5% showed conditions on dark skin tones. This is also reflected in our clinical practices. So when we're looking at the assessment of the APGAR score, one of the components is colour, and still now often the words we describe are blue and pink. This is not inclusive at all of a very diverse population of people we look after in terms of skin tones, and not, for example, a baby with black or brown skin will not necessarily be pink, which is well perfused, or blue at birth. This leads to a massive lack of knowledge and understanding of the clinical presentation of maternal and neonatal conditions on black and brown skin. And also in terms of jaundice and things, we often use the term yellow skin, which may not be immediately obvious on someone or baby with black and brown skin. So this can lead to missed or late detection and diagnosis of harmful conditions. And I've put here it can lead to poor clinical outcomes, but it also leads to really poor experiences as well. Next slide, please. So when we're looking at the kind of quantitative data around statistics, Black women are 3.7 times more likely to die, and Asian women are 2 times more likely to die in pregnancy, childbirth and postpartum, and are also much more at risk of experiencing a near-miss event. So I think it's really important when we're not just talking about morbidity and mortality here, we're actually talking about other things that aren't always necessarily reported as well, near-miss events that lead to longer term morbidity. And also Black babies now have the highest rate of both of preterm birth, stillbirth and neonatal death. And this is the highest it's been since 2016. So when you actually look at the graph, it's gone up, which was really shocking and awful that this is still happening now, despite, our advance in research. And to me, it was a massive sign that we need to just bring in as much more practical solutions as we can to try and address this. So next slide, please. So as well, beyond looking at the quantitative data, I looked into the qualitative data, which is obviously just as important. And it's, I think as well, looking beyond the numbers, these are people's lived experiences, and reading some of these experiences was really, it's really upsetting as well. And for a lot of women that have experienced such unfortunate events, a lot in the lead up to this, a lot of women described feeling very othered, invisible, ignored and scared as a result of their treatment in our care sometimes, and felt like signs and symptoms of conditions were often either downplayed or missed completely, leading to often emergency situations. So sometimes they weren't picked up with the earlier cues and signs, it was picked up later down the line when unfortunately the prognosis was much more poor. So this anticipated inequality of treatment as well can lead to distrust and disengagement, which in itself, if people aren't engaging or feeling very distrustful before they'd even walk through our doors, this can lead to a range of other potential consequences too. Next slide, please. So this is, I've kind of gone forwards to go backwards, but where some of the idea kind of stemmed from was during my trip to Ghana in the second year of my studies in 2023. And it was during my time here that we worked in a local hospital and then a more kind of bigger hospital. And in the local hospital, we went to the neonatal unit, and they were showing us a baby that had jaundice. And they were saying, you know, we look at the palms, we look at the soles of the feet, and the whites of the eyes, and they weren't just saying, you know, we look for yellow skin. They were looking in places where I hadn't previously been taught to look in a baby with black or brown skin. And, you know, after looking in those places, it was, you know, very obvious, but it wouldn't have been immediately obvious, which is something that, although it might sound, you know, obvious if you're a more qualified person, to me in my training, it's something that I was never taught. Next slide, please. So this kind of planted the idea of the seed, as well as me noticing that there was a lack of representation in my studies and in practice as well, in terms of, you know, posters up on the wall, the leaflets we hand out, the words, the language we use. This led me to wanting to focus on it for my dissertation, like I said earlier. And I also was in the era of midwives where we went from paper notes to digital notes, and we often would signpost women to their online portals where they would access information. So I then reached out to someone called Malone Mukwende. He did the book called Mind the Gap, which some people might know about. It's the first clinical handbook to show conditions on black and brown skin. And he said to me, he pointed me in the direction of someone else, who then told me to apply for the NHS Clinical Entrepreneur Programme, where I then went on to network with some people and got through to the final round of a challenge which was being run called the Priority Population Digital Health Challenge. So this was all about bringing a digital health solution to an undeserved population. And my idea for it was melanatal, which was the app I focused on for my dissertation. Next slide, please. So here we go, here's melanatal. You can see a tiny little snapshot into how it looks here. It's basically at the minimum viable product stage, so the prototype stage, and it's now in the piloting stage as well. Next slide, please. So melanatal is a digital health education tool in the form of the app, which equips birthing people and clinical staff, as well as students, with a better knowledge of the clinical presentation and signs and symptoms of a range of maternal and neonatal conditions on black and brown skin, such as jaundice, cyanosis, rashes. So it has basically medical illustrations, and then also talks about the signs and symptoms, and then it signposts people to various resources as well. It's not only just the visual presentation, but it also talks about a range of conditions that are also more likely to, that are more prevalent amongst black and brown women and babies. So, for example, it talks about sickle cell in pregnancy, as well as things like postnatal depression, which is more prevalent amongst black mothers too. So a range of things. It's not just about the kind of visual presentation. It talks about a whole range of conditions. And also to mention as well, in terms of babies, it discusses congenital melanocytosis, which is a newborn birthmark, which is a lot more common amongst babies with black and brown skin. And sometimes, unfortunately, these can be mistaken as bruises. And although they're not harmful for the baby, if this is not picked up by clinical staff at or around the time of birth, it can be picked up by health visitors when babies go home. And unfortunately, there was a case which was in the news where this wasn't picked up by clinical staff, and unfortunately that mother was taken in for questioning at a local police station because they thought she had harmed her baby, when in fact these marks they used to be called slate grey nevi. They're called congenital melanocytosis, and unfortunately those were picked up as bruises rather than the birthmark, which is very prevalent amongst, as I said, babies with black and brown skin. So the point I'm trying to make is it's not just about conditions that could be harmful. In this case, this condition isn't harmful itself, but the consequence of this being missed was that that mother ended up in a police station being questioned. Next slide, please. So the features of melanatal, we have images and information. So this is to be basically a visual aid and make it really clear for those that you know, writing might not be as easy for them to understand. In the future, I'd love to incorporate translation as well of the information into a range of languages, and also I'm going to bring in audio as well so people can listen to the information, and a share and upload feature which is in the works of people basically uploading pictures. Because of the extremely fast turnaround, I was literally started developing it last year in summer and as a student, and I'm now just a newly qualified midwife, so it's been a really quick kind of development from the idea being taken on from the company and then us building it, so hence that it's still in the works. But yeah, next slide please. And I'm also as well, just to say that I'm working with someone called Chidi Berry Ebe. He's a Nigerian born medical illustrator, and some of you might know his medical illustrations. If not, in the meantime, please look at his illustrations because they're absolutely amazing. He's kindly donated some of his imaging and done some for me, which we're using within the app and working together on that. And yeah, his images are absolutely amazing. In the meantime, if you needed it for any learning resources. So the aim is to educate, because education is the bedrock of knowledge. And as I've said, there is absolutely, you know, no shade on any of us as practitioners or for us not having this knowledge. It's just not being available. And that's the main thing, is that now we know better, as that phrase, I think it was Oprah Winfrey said, we need to do better. We have this knowledge. We've done a lot of research now. There's still more to be done, but we do need to now work towards taking practical steps. And that's why I was so passionate about it as a student, because I just felt like there was so many of these reports coming out and so much, you know, so many kind of promises, we're going to do this, we're going to do that, and I was like, where is it? And I was just really keen to have something, or at least as well, I think for those mothers and families within our care, knowing that there's even an initiative or a project that is focused on, you know, we're doing something, we want to improve your care, that in itself is really shines like a beacon of light and hope for them, which I found a lot of the feedback for people. They said it's just great to know that something like this is going on. So yeah, of course, we want to aid detection and diagnosis to ultimately improve outcomes. But as I've said, I just would love to improve the experiences of these families within our care. And that's the first port of call, is just to improve experiences. And then long term, hopefully we can audit things and see if the outcomes have also improved. Next slides, please. Oh, right. So yeah, that's the end of the presentation. If you'd like to contact me, please feel free via LinkedIn or the website as well. You can fill out a form and my email's there. I think that's wrapped up.
Thank you so much, Ruby, particularly or especially for taking time out of your busy clinical schedule as well to give us an overview of what sounds like an or is an inspiring um, innovation. And actually, it's a reminder of how innovation, when it's guided by inclusivity, lived experience, and true need, it can truly transform care and most certainly address inequities in a meaningful way. Quick question. I know you've put your details on there, but if people want to follow progress of what now is an MVP and or maybe even contribute, how can people do that? Is it still through the same contact details you've shared, or is
Yeah,
there?
so
Yeah,
yeah, if you want to follow us on socials or through the website, the best thing to do would be to sign up to the mailing list, or just keep your eyes on the website for updates. But yeah, it's in the works. We're trying to do it as fast as possible. I've literally been pretty much a one-man band this whole time. Obviously, I've had a lot of support from the app development team, but yeah, it's been quite a kind of snowball, quick turnaround. So yeah, we're working as fast as we can. But yeah, if anyone wants to get involved or contact me, just fill out the contact form. It's actually on the website.
fantastic. And not to embarrass you, I think you're a bit of a celebrity as well. You featured on BBC News, didn't you? So I've put the
Yeah,
link in the chat.
yeah. I know, because my university basically put out a press release about it, and then it just got so much traction from like NHS England and then the BBC as well. So it was quite overwhelming because I'm still just quite young, quite new to the world of, you know, TV and stuff is not really my thing, but you know, I'm just trying to get the word out there and just get us all trying to do what we can to move forwards.
Thank you. And if anything, maybe that's a call to action to promote this
Yeah.
work, raise awareness. Colleagues or a colleague from the Health Innovation Network actually made us aware of this, and don't want to embarrass her if she's on the call, Rachel Garrett. So thank you, Rachel, for the connection to Ruby's work. There's a question on there around what difficulties you encountered while developing this, but hopefully that's something, if you can
Yeah.
respond to that very quickly before we go on to our break.
Luckily, I'm using with a company that they use no code, so it's basically I only had to, like, there's only small bits of coding that I had to learn to actually do the app, and aside from that, it was really easy. It's basically has everything I've put input the illustrations, the information, everything like that. So in terms of the app build itself, it's not been too difficult. I think just actually getting things adopted in the NHS is obviously quite hard. There's a lot of procurement procedures and things like that, but that's almost just the kind of admin side of it. I think just actually it being such a wanted thing, and I'm just trying to get it out there as quickly as possible, because there's just been an influx of interest from the families, which is the main thing, that I just really want them to be able to use it and get involved. So that's the main thing, has just been trying to get it out there as quick as possible.
Thank you, Ruby. It's iterative, isn't it? And as needs change and become more complex, I suppose the innovation will sort of move with those needs and
Exactly.
respond accordingly. But
Yeah.
brilliant presentation, brilliant insights, and brilliant work. And thank you so much for taking the time to talk to us about melanatal. So, yeah, hope
Pleasure.
you have a good rest of your shift.
Thank you. I will do. Bye,
Take
everyone.
care.
Have a good
And we'll give people a few seconds to return just before we introduce our next speaker. Thank you very much. Welcome back, everybody, and hope you've been enjoying the webinar thus far. I most certainly have, and the enjoyment hopefully continues, as well as the learning and the insights. So it's now my pleasure to introduce our next speaker, Dr. Liz Ford, who's an associate professor in health data science at Brighton and Sussex Medical School. And Liz has extensive expertise in using real-world data to tackle complex challenges in healthcare, particularly in addressing inequalities. So today, Liz will be guiding us through the data landscape across our sub-region, Kent, Surrey and Sussex, and exploring how we can use routinely collected data to address health disparities. Liz, I do not want to steal your thunder, so I'm going to pass the mic to you and let you talk us through your content. So welcome,
Thank
Liz.
you. Okay, well, thanks ever so much for the opportunity to speak today, George. And I don't quite know how to follow that brilliant presentation by Ruby, but I'll do my best. So I'm here today to talk about using real-world data to address health inequalities in Kent, Surrey and Sussex. I have been asked to cover the following things. So I've got a few learning aims or things that I want to share with you. So I want to cover what is real world routinely collected data. We've already heard a bit about that, and I'm hopefully assuming that you've already got some knowledge, but we're going to talk about other types of sources that we could look at. I want to cover an overview of the data landscape in Kent and Sussex, and then how we can use data for these kinds of data sets for addressing health inequalities, but what challenges there are with them, such as addressing biases in data, thinking about how you can design data research or analysis to create impact, and then a bit of signposting about how to get started and what resources there are. So first of all, my job title is that I work in health data science. So I just wanted to cover what that means to me, and why I've been invited here to talk about routinely collected data. So health data science is an area of research which uses the application of data science methods on healthcare data, usually routinely collected healthcare data. And because that's messy, and data sets are large, it involves cleaning, collecting, analysing, interpreting these large data sets. Often what we're doing with our tools and techniques are trying to characterise disease diagnosis and prognosis, perhaps trying to make predictive models. We might be doing drug discovery and development. We might be trying to develop personalized medicine technologies. Sometimes we use these techniques to improve the efficiency of healthcare systems, for example, forecasting service demand at different times of the year or the day, and then also addressing population and public health challenges such as epidemics, health disparities, and chronic diseases. And health data science relies on conventional statistical techniques. So I came into it through epidemiology, so descriptive statistics, hypothesis testing, and regression. But we also branch into machine learning, which is emerging, such as deep learning and neural networks. We're really interested in natural language processing because a lot of medical notes, reports, and letters have useful and interesting clinical data in unstructured text. And then also we've heard a little bit about creating dashboards, so creating visual representations of data to quickly communicate findings in real time is very valuable as well. So another definition I want to go over at the start of this talk is what we mean by real world and routinely collected health and care data. So real world data is information about patient health and healthcare delivery that's collected outside of clinical trials or formal kind of research studies and surveys. So it's basically data collected during patient interactions with the health service. And the data that I'm most familiar with using is from GP clinic notes. So that could be free text data, prescription data, and coded data, and things like referrals or tests or test results. Hospital data, which is often recorded for reimbursement for episodes of care. So data from the emergency department, the outpatient department, inpatient care. There's a lot of clinical information in discharge summaries and in scan results, lab tests, and pathology reports. I've also conducted research on mental health patient notes, which are written in plain language, so need some machine learning to structure them, some coded data. We can also use nursing records. We can use disease registries. So there are national disease registries for cancer, for MI, that's myocardial infarction, for heart attacks and other infectious diseases. And these can be linked with patient reported or research data as well. And very slowly, we're starting to look at routinely collected social care data. But we must also consider other sources of health data which can tell us a lot about information, but which I'm less familiar with using. So image analysis, so it might be MRIs. They can tell us a lot, for example, about brain diseases like dementia. Increasingly, patients are generating their own data through wearables or reporting data in apps such as tracking menstrual cycles. Increasingly, screening tools around cognition or mental health and other things are presented to patients on phones and tablets. Patients also can write quite a lot about their health in social media, which becomes kind of open information on the internet. And then also increasingly for, say, care of the elderly, sensors can be placed in a patient's home to look for risk of falls, for example. And these can all be linked together and or linked with health data to give a wider picture. And increasingly, especially as we're talking about health inequalities, we're particularly also interested in wider determinants of health that we might want to link into a patient's health records. So financial information, educational information, geographic and environmental information might all be quite interesting. Hopefully you'll get a copy of these slides at the end because I've put quite a few links to websites and papers in the slides that you'll be able to look up afterwards. Now, I've talked quite a bit about linking data together. So data linkage is the joining of information from 2 or more different sources, and that information relates to either the same person or the same family. So for example, we could link mother and baby data together and look at outcomes, or they relate to the same place. So we could look at sort of geographical variations or the same event. And linking data helps us to create purposeful data sets to answer more questions, particularly thinking about data that's routinely generated, and so we don't have to go out and collect data, which can be resource intensive. It will help us give a more thorough picture of health and wider determinants and outcomes. And we get a more complete or higher quality picture on a person. So for example, linking multiple sources of NHS records might give us a more complete picture of the ethnicity of our patient population, because ethnicity is entered at least into one of those sources. And often when we say data linkage, what we mean is those data sources aren't exactly joined together, but the identifiers are removed and the patient is given a pseudo ID, so a made up ID number, and the same person is identified by the same ID number in all data sets, and then the analyst can then trace an individual across those data sets. And they're provided with those de-identified data sets, usually in a secure environment for their analysis. So just a quick example of what this might look like. So there was a randomized controlled trial where half the babies were given nutritionally enhanced milk formula and the other half were given standard milk formula. And they thought that this might improve brain development. And so using linked data, they went on to look at their results in their exams at age 16 as a really long-term follow-up. So they linked the data from the trial, well, actually 7 randomized trial, with maths exam results from the UK National Pupil Database. And what happened was a trusted third party, so it's often some part of the NHS within NHS, it used to be NHS Digital, would have access. I mean, this doesn't actually use NHS data, but the same type of thing would happen. A trusted third party would use names, postcodes, and dates of birth to create pseudo IDs for the participants in both data sets, and then the data sets could be analysed together. But it was found that there was no improvement in maths performance at 16 years of age based on this enhanced milk formula. Okay, so that's a kind of background whiz through all the things I want to talk about. But I thought it would be really important today to talk to you all about what data sets are available in Kent and Sussex. Now, obviously, Health Innovation Network is Kent, Surrey and Sussex, but this webinar is specifically focused on Sussex. Sussex is working with Kent to develop data infrastructure that is shared across the 2 counties, because both of them have created these integrated data sets. So we heard a little bit about the SID. So I'm going to come on and talk to you what that is in a few minutes. But basically, Kent has a very similar one, a Kent integrated data set that has linked coded data from all NHS providers. And in Sussex, we also have some adult social care data. This is de-identified at source, and every person in that data set is given a pseudo ID, so we can trace that person across their different uses of different NHS providers in Sussex and over time. At the same time, but separately, mental health notes from Sussex Partnership or Kent Partnership, so they're the mental health trusts, are being fed into a system called CRIS, which means Clinical Record Interactive Search. And this is run by a small spin-out company called Acrivia Health that used to be part of the University of Oxford. And they host this free text mental health data securely in a data safe haven. They apply artificial intelligence analytics to it to structure clinical information for analysis. So pulling out the relevant clinical concepts, symptoms, diagnoses, etc. And then they present that structured data back to the NHS so that trust analysts can conduct audits and do research. But increasingly, they're making this available to researchers like me who work in a university. These two pieces of data, as I said, at the moment, they're separate, but hopefully in the future they will be able to talk to each other. So this is what the Sussex Integrated Dataset looks like. It's a bit of a busy slide, but let me just quickly talk you through. So in the top left corner, in sort of light purple, that's all the data feeding in from primary care. So that's GP practices, and it's about 95% of GP practices are flowing data into the SID. Down in the bottom left-hand corner, in the sort of dark rows, that's the hospital trusts feeding in emergency inpatient and outpatient care. The kind of magenta is from the ambulance service. Then we've got social care data going in, community data, and a little bit of mental health data. So just the structured and coded data from mental health. And this is, as I said, it's all de-identified at source, but the same patient can be found across data sources because of this pseudo ID that they're given. Now, these two data sources from Kent and from Sussex are being put into something called a subnational secure data environment. So this is a national or England-wide initiative funded by the NHS England Data for R&D programme, and every region of England will have its own secure data environment. Now this is like an umbrella of security, governance and technological infrastructure that goes over the top of these data sets, which sort of hosts panels and committees for judging applications to use the data, creates user accounts for bona fide researchers who want to use the data, such as someone like me from a university, and then gives them access to just the data they need for a project in a controlled environment where they would log into this kind of virtual space on a cloud drive. And so it keeps the data within the NHS behind the firewalls and allows bona fide researchers with approved projects to log in and get access to analyze that data for research. So the Kent Medway and Sussex Secure Data Environment has got two launch events in February, which you're very welcome to attend. The Brighton-based one is on the 26th. So if you're interested in that, drop me an email. I'll send you more information, or you can look for it on this website. The link's there on the left. And this is, as I said, part of a national set of initiatives to make these data sets that are springing up around the country as a result of the kind of STPs that were, digital programs that were initiated sort of 5-10 years ago. They are not exactly hosted, but information about what is available in terms of data is all being collated into this national gateway, which is run by Health Data Research. And you can see down here on the left, it says, but data sets. If you click on that, you get a list of all these data sets which are becoming available to researchers and more information about how to apply for them. So if you're interested in a national data set or something quite bespoke or specific, that's a good place to look. So coming on to sort of what are we going to do with the data now? Now, we all hear about health inequalities and disparities. So I just want to talk for a minute about the types of health questions we can ask and answer with this real world data. When we're starting to think about the questions we want to ask, not necessarily research, maybe audit or analysis, we need to form our question around the data that's available. So we are stuck with what gets collected and its quality. So we can only ask questions if the data has been collected and we know it's reasonable quality. And we need to remember that electronic health record data is recorded by the clinician. It's not sort of self-generated by the health condition of the patient. It depends on that interaction. So having information about someone's condition depends on the patient telling the clinician and the clinician recording it in the record. So you've got the patient with their symptoms. They may or may not, but we hope they do have a consultation with a clinician, a GP perhaps. They give the GP some information. The GP might do some examinations, order some tests. And then it's the GP who inputs that information into the computer. We don't know how much of what's going on for the patient has been captured. and we don't know how much it's been filtered as it's gone into the computing system. We don't know how much we might have lost in something like the SID by information being coded in being entered in the free text. So we need to just consider when we're designing our projects some constraints on what data might be there. Here are some example constraints around coding structure, the interface, the ease of use of coding something rather than putting it into text for the clinician, the time available they have for documentation. So some AI is springing up which is listening to consultations and documenting them and suggesting ways of usefully documenting them during the consultation and being trialed in GP settings, which is really exciting. We've got to remember what the motivation for documentation was. In hospital data, it might be billing, which might give a different picture than if you looked at the notes of the patient. It might be a record for the clinician's own memory or to inform the next clinician. And sometimes it will be about sort of safety netting the clinician and saying what they've checked and what they've ruled out. We also need to consider clinical reasoning and filtering of information, what's most important to the clinician, what biases might they have, and also whether the clinician is considering any secondary purpose of the data, which they often might not be, but increasingly can be encouraged to do. So I want to encourage you, despite these difficulties, to consider using these data sources to address health inequalities, and these are some of the reasons why. One is we can research the needs of underserved and seldom heard groups, because we know that 98% of the population is registered with a GP and has access to see a GP. So if we're using primary care data, that means we probably have a much wider reach than if we go out and recruit patients into a research study, because some demographic groups are known to be less likely to take part in research because of historical practices that have excluded them. These can be minority social and cultural groups, ethnic minority adults, older adults, people who are living in lower socioeconomic circumstances, and people with disabilities or with caring responsibilities. And these are the people we really want to know about what their health needs are. A second reason for using these routinely collected data sets is that we can trace patient journeys through different parts of the health system and look at how our health systems join up to create safe care, or where patients might fall between the gaps. Now, in this case, this was generated from Sussex data for a single patient over time from 2017 through to 2022, and looking at where they use different parts of the system. So we've got emergency admissions to hospital, we've got A&E visits, we've got social care starting, we've got mental health referrals, and we've got community visits. So we can see how those different uses of different services interact with each other, and whether, for example, social care is starting in a timely way when a patient is discharged from hospital. One of the reasons that the ICB was really interested in using this data originally was around addressing diabetic foot problems. This is just an example, but it's so diabetes can lead to a number of foot problems because of damage to nerves. Loss of sensation then means that cuts and blisters and burns go undetected, and poor blood flow might mean that a wound that goes undetected doesn't heal, and then an ulcer might get worse and worse, leading to an amputation. So the ICB wanted to see where diabetic foot care to prevent these problems emerging could be provided, and where patients were slipping through the net and not getting this kind of care. So by using linked data, they were able to learn more about patients' ongoing and preventive diabetes care, and have a better view of patients' journey through the system to do more prevention work. A third reason why we might want to use these data sets is that we can see what's happening over time and place within the population. So not just for an individual journey, but in terms of, are we seeing different places in Sussex having different levels of multimorbidity, so multiple long-term conditions. In this graph, we've got results from a GP practice. Across the bottom are the ages of the patients in that registered at that GP practice, and the coloured lines represent how many long-term conditions the patients have. So we can see that when they're younger, there's a greater proportion of patients with no long-term conditions, and as they get older, sort of 60 and above, nearly everybody has at least one long-term condition. Lots of people, above half, have two or more, and that number goes up with time. And what we could do is look at different GP practices with graphs like this and see whether certain areas, perhaps more deprived areas, have an earlier onset of multiple long-term conditions than other areas that are less deprived, for example. This was some work by my colleagues at the University of Kent, and they were looking to compare long-term conditions in Dover, which is a deprived coastal town, against the average for Kent as a whole county, and showing which of the particular long-term conditions were most prevalent in Dover in comparison to Kent as a whole. We can see that ADHD and learning disabilities were overrepresented, and then chronic kidney disease, irritable bowel syndrome, and stroke were also quite a lot more common in Dover compared with the rest of Kent. But I do want you to consider that some biases, even if we can look at data across, hopefully almost all the population, this data is generated by ordinary humans with ordinary biases, and we know already what types of biases are existent in our healthcare. So we've heard already about how Black and brown people may face discrimination or poorer healthcare than white people. We know that there's gender bias in healthcare, particularly around, for example, women's pain. We know that LGBTQ plus people can be prevented from accessing appropriate healthcare. People with disabilities might find it difficult to access healthcare, and even people living in larger bodies might have difficulties with healthcare. So we need to make considerations about this when we're using data. One of the things that we have been looking at with colleagues in Kent is trying to find out who or what is missing from a data set, or who is underrepresented. So we can do this with, for example, census data. If we look at the sort of in a certain geographic area, who should be in the data, for example, proportions of people from different ethnicities, and then we look at our healthcare data from that area and find there's fewer, say, people from an Asian background than we're expecting, we know that they are potentially then missing and underrepresented in our data set. So there's a lot of open source data about wider determinants or protected characteristics that we can use. So these are just maps of East Sussex, life expectancy and economic deprivation. This is one of the maps that you can get from census data 2021, which shows in quite detailed granularity educational qualifications in Brighton and Hove. And, for a small city, it's interesting how people from different backgrounds cluster in different areas. So we can use these kind of geographical piece of information to tell us either about the wider determinants of people in our healthcare data sets, or to try and find out who we might be missing and how representative these data sets are of our population that we're expecting to see. Okay, so that's quite intense. I just want to talk for a couple of slides on how we can make our data-intensive research or analysis more impactful. I'm really a great flag waver for inclusive research teams where we have health and social care practitioners and public and patient contributors in our data teams, and research teams and project teams. So flying the flag for that. I really feel like we should do stakeholder engagement in our data work right from the beginning. It helps us design projects to meet population need. And then I just wanted to flag for you our Data Hub resource website that we've created. So this is under the BSMS, so that's Brighton Sussex Medical School website, and it's bsms.ac.uk/ARC Data Hub. It's funded by the Applied Research Collaboration in Kent, Surrey and Sussex. And we've been creating beginners guides for using these kind of data set resource guides for how to apply and find out what's in these different data sets, national and local ones, and blogs on recent innovations in this area. And we often update and add more resources to our website, and there's ways of contacting us through that. So that's the end of my talk. This is how you can contact me. But in order to see the Teams call, I have to stop sharing. So hopefully the slides will be circulated. Thanks, George.
Thank you very much, Liz. And yes, the slides will be circulated, and we've posted a few links to signpost to some of the things you mentioned, like the SDE and the SID, amongst others. And of course, thank you for sharing your email. And more importantly, thank you for such an insightful and practical session. Of certainly, that's what I found it to be. And you've taken what can sometimes feel like an overwhelming or complex topic and certainly made it accessible and relevant. And we're trying to make population health everyone's business, and consequently make data everyone's business as well, whether it's qualitative, quantitative, and just the principles that we sort of need to abide by to do that, regardless of background or familiarity or exposure to data. So thank you for that. We've had a few comments in the chat. I think there was a question. I think there was one around skills. James, I think it was James Webb, who highlighted or expressed how much he likes these ideas and always wanted to get into machine learning. So if someone wanted to get started, are there any resources or tools you might want to signpost to in particular?
So in terms of starting with this data, if you're going to access the SID either directly within the health system or through the SDE, you're going to need to have skills on something like Python or R as software and statistical programs for data management, because this data is not created as a nice clean research data set. There's lots of data cleaning and processing to do to get it into an analyzable format. So it's really good if you can mug up on your data skills for sort of selecting in, which variables you're going to use and things like that. We're really happy if you contact us at this ARC Data Hub to signpost you to online platforms and also some online training courses for those software packages. And there are quite a few week-long intensive courses on how to analyze electronic health records data, which are put on by different universities, which are really great training grounds if you can get a week off from your day job and go and study. Often they're online, and they'll whiz you through how to analyze this kind of data. We're trying to have an up-to-date list of those courses. But as I said, there's beginners guides, there's data resource packs and other things on that website, and I'm happy to always answer questions via email as well if people are interested. Really, my funding, research funding from the ARC, so that's the NIHR Applied Research Collaboration, is around building capacity to analyse these data sets in our region. So really happy to talk to anybody about this. And also Jacqueline, who was on the call, as line managed people analysing the SID and other things. So, within the local authorities, there's some really good expertise as well.
Thank you, Liz. So a plethora of resources and people to contact, and it's a journey, isn't it? So and hopefully not leading down a rabbit hole. Sometimes it can, depending on what the question is or what the investigation is. But in short, there's lots of data out there, just navigating it, knowing what to do with it, and what answers it gives us, and more importantly, what interventions does this data help us design meaningful interventions with lasting outcomes.
Yeah.
Just trying to see if there are any questions. We'll share the slides. So for those who are on the call now, on the webinar now, and those, of course, who are watching the recording back, hopefully we'll have the slides as well. But thank you once again. And
so there's a question from Gillian in the chat. How do we factor in the fact that research might be biased and is already baked into data, given all the new AI tools we're using? I'm actually giving a talk on that next week at the event in Moulsecoomb, George. So I have got slides answering that question, which I could send over to be circulated for Gillian and others who are interested. But it is a real problem that the data that we train AI on has these systemic biases in it. And we need to be really cautious that we're not replicating and increasing biases because we're relying on AI that reproduces these biases. But there are methods people have used to understand and reduce those biases.
Sure. I think you sparked some interest now to those slides that you mentioned. So if you can share those with us, then maybe one way we can do it is as part of the follow-up comms from this webinar, we could share that with participants today. So yeah, rest assured, everyone, you'll get those slides as well.
Okay.
Thank you so much, Liz. And hopefully we can hear more from you about this work, either this year or the next, or whenever we have another opportunity to have a captive audience as we've had today. So thank you once again.
Lovely. Great. Thanks, everyone.
Thank you. Right. Time flies when you're having fun, hopefully, or learning lots. We are now going to have an interactive poll. So at the very start of this webinar, we asked you a question about where you thought your knowledge and confidence is with regards to this topic, using data for better health outcomes. And hopefully, following the information you've heard, the presentations you've seen, the links you've seen as well, we recognize that, in a couple of hours, there's only so much you can absorb and digest, let alone apply. But hopefully, it's given you a bit more insight and confidence to tackle what might have seemed like a daunting and challenging area. So we want to ask the question we asked at the start again, and we are going to launch a poll.
Thanks, George. I started by saying it was great to see so many of you on the call today, and I just wanted to thank you for all attending the webinar today, and to our speakers for such an inspiring and insightful session, which has really shown how data and digital tools can be transformative in tackling health inequalities and improving outcomes for our population across Sussex. Jacqueline highlighted the population outcomes framework, which we've worked on across Sussex through co-production, and will really help us improve life expectancy, health life expectancy, and reduce the gap in life expectancy for different groups of people across Sussex. Lucy reminded us of the health equity framework and how its principles, alongside the Sussex Digital Inclusion Framework, can help address structural biases and ensure that digital solutions are equitable and inclusive. We had a brilliant presentation from Ruby, bringing to life the melanatal work, showing how co-production and inclusive design can make a real difference for underserved communities and individuals and transform their care. Liz demonstrated the power of real-world data, and I personally learned so much during that presentation. She offered real practical examples And as a podiatrist, I was really able to relate to her information around the diabetic foot example. So it really brought it to life for me. It was exciting to hear how linked data sets can uncover inequalities and guide targeted innovations. And a good reminder to all of us that data is affected by structural bias, and to really ask ourselves who can be missing from our data sets. And I think there was comments in that around that in the conversations as well, which we can revisit and think about. I've personally made a note to visit the website and think about how we can share resources across our Population Health Academy webpage, and colleagues. So today's webinar has not only provided valuable insights, but also that clear call to action about to consider how we're using data, where the biases might sit in that, and how we can share our knowledge across Sussex. We really must ensure that equity is embedded in everything we do, whether that's collecting and analysing data, supporting digital inclusion, and again, much work has been going on across that in Sussex, or co-designing solutions with the communities we serve through things like our Digital People panel. We continue to grow and evolve the Sussex Population Health Academy to support you, but real change will really come from the collective efforts of everyone in this room and by sharing that with colleagues. So thank you again for joining us, and let's continue working together to create a fairer, healthier future for our population in Sussex. Thanks, George.
Thank you very much, Kerry, and to all our speakers, and most importantly to all our participants today. You've made this, I guess, the success it has been in terms of the engagement and the conversations in the chat and the signposting and opportunities for further conversations on various topics, covering all the content that we've explored today. So thank you for joining us and for engaging. It's quite a can be a heavy or loaded topic, can't it? Data and digital as well. And we often say, or I've heard people say, and I echo this as well, we can be data rich and insights poor often, and not just in our health and care system, but just in the world that we live in. So much information, but also misinformation. So it's not just about having the data, it's about what we do with it. It's not just about analysis, it's about action. It's about finding the gaps, engaging the right people, and creating solutions that are not only sustainable, but more importantly, inclusive. So thank you all for participating and helping us continue on this journey. This is not the end though. We've got 2 more webinars over the next couple of months, and the next one is going to be equally exciting and insightful, and is going to be focused on equitable commissioning. And there was a question earlier in the chat and a conversation around that. So this will be an opportunity to explore that a bit more. So on the 26th of February 2025, which is not long. Can't believe this year is just whizzing by already. At the same time, join us to hear about how we can embed equity in commissioning and ultimately address systemic barriers and equitable financial access as well. So do join us for what promises to be another insightful session. And finally, I know you might feel I robbed you of 5 minutes of your break earlier, but hopefully we can give you those 5 minutes back by wrapping up 5 minutes earlier. So many thanks for everybody who's joined. Many thanks for your contributions. Many thanks to our speakers. And we hope you have a great rest of the week. Stay warm, stay safe, and see you again on the 26th of February.